Well, good afternoon, everybody. My name is Bill Goodnight. Again, I want to welcome everybody to the next in the SMFM Fellow Lecture Series. Very exciting. Starting next month is our research series, starting the third Wednesday of July. So it looks like a very great program. Allison Cahill has set up an amazing set of lectures to go over the next year. So look forward to that. July 4th is a Wednesday. It's a holiday. We will not be here. So no lecture on July 4th. Again, as typical today, we have a great invited speaker, Dr. Sean Blackwell, giving a lecture today. At the end of the lecture, you'll have an opportunity to ask questions. So please feel free to send us those questions. At this point, I'd like to turn it over to Dr. Blackwell from University of Texas Department of Obstetrics and Gynecology. And Dr. Blackwell has graciously agreed to give us an update on fetal monitoring.
Thanks, Bill. Can you hear me okay?
Yes.
All right, well, I want to thank Bill Goodnight and then Gene Sheffield for the invitation, and it's certainly a pleasure to talk with the fellows through this, and this is something that's near and dear to my heart. I'm going to focus in on an update in fetal monitoring, really talking specifically about the NICHD 3-tiered classification system, kind of go into a little bit more detail, sort of talk about the back end of how some of the decision making was done for that classification system, and then talk about what some of the alternatives were and still may be, and then talk about some of the research that's been published in the last few years regarding the system, and try to talk about how that information we should incorporate how we use the system. So I don't have any financial or relevant disclosures, and I'm not going to talk about anything off-label. So I'm really going to focus in on the 3-tiered classification system. As I go through, I'm going to talk about some of the strengths, limitations, and lessons learned since adoption. You know, it was published in 2008, so it has been several years already. I'm going to talk about the 2-tier and 5-tier systems, and then kind of talk a little bit about future directions. There are some interesting things that are going on with new technologies being tested, in particular ST analysis as an adjunct to fetal monitoring. That's beyond the scope of the presentation, but I'm more than happy to answer some questions afterwards. I think that's kind of a discussion in amongst itself. Certainly, once the ongoing NICHD maternal fetal medicine units networks trial is completed, I think we'll have some information about that technology. So just to kind of set the context, you know, I did my fellowship in the late 90s, and fetal monitoring was a given. It was something that had been used for many, many years. Intermittently, for the sake of academics, we as all fellows would go back and look at the randomized trials of electronic fetal monitoring, look at the systematic reviews, and have somewhat of a philosophic discussion about whether or not we should be doing fetal monitoring, or could we go back to intermittent auscultation, or what we should do. I have this slide here. It's a very interesting commentary that was published in the Green Journal a few years ago by Dr. Grimes and Dr. Peppert, which I think keeps this academic discussion alive. I think it's very interesting, and I would encourage all fellows to read it. My point here is that there's still a lot of controversy of the role of electronic fetal monitoring. The other thing that I think is important to just set the context, you know, fetal monitoring has been tested in clinical trials. All of these trials were done long before I became a resident or fellow, so they're all quite old. They were comparing continuous monitoring to intermittent auscultation. The findings showed no differences in perinatal death, certainly no differences in cerebral palsy for those trials that did a longer-term follow-up. There was a statistically significant reduction in early onset neonatal seizures, which is a surrogate marker It was postulated to be a surrogate marker for intrapartum hypoxia. And it's well known and described that the intervention rates, both for cesarean delivery and operative vaginal delivery, are significantly increased with the use of electronic fetal monitoring. With that being said, it's my opinion that it's thoroughly unlikely that at this point in time in 2012 we're going to abandon continuous electronic fetal monitoring. And I think the best strategy, other than to have, some esoteric philosophic discussions over wine about whether or not we should abandon electronic fetal monitoring, it's here and now, every day, taking care of our patients. So I think that my approach is to have a pragmatic approach to recognize the limitation of the technology, the limitations and strengths of classification systems, and then try to do with it the best that we can. So I think our role as fellows certainly is to take care of patients, but I expect our fellows to train the next generation of residents and obstetricians as well, and I think that situational context is really important. So what's the realistic expectation of electronic fetal monitoring? Because I think this sets the stage for what we expect out of the classification system. Really, electronic fetal monitoring is designed to identify patients who are at increased risk for intrapartum stillbirth and fetal compromise due to uteral placental insufficiency, and it really tells us very minimal information. It provides information on fetal oxygenation and acid-base status at any given point in time. In my mind, I'm very cautious about saying that electronic fetal monitoring can time brain damage or provide other information about fetal well-being. I try to be very concrete on what fetal monitoring can do. The other limitations that we need to be aware of, fetal monitoring is a diagnostic test. We need to recognize that this test has a high false positive rate. You certainly can have abnormal fetal heart rate parameters, but normal oxygenation and acid-base status, especially if you get overly deceleration driven and don't focus in on fetal heart rate variability. There's plenty of research data that suggests that close to a third of cases when there's normal birth weight, umbilical artery pH, Apgar scores still have episodes of abnormal fetal heart rate pattern during labor. And I'm very cautious about the use of fetal monitoring beyond providing information on oxygenation and acid-base status. So in 2008, the workshop report was done. It was a group of experts and multiple stakeholders, those from the NICHD, Society of Maternal Fetal Medicine, ACOG, A1, and other stakeholders, with the goal to try to update where things are and try to improve on our existing usage of electronic fetal monitoring. The prior consensus statement came out in 1997, and there was thought that we needed to take additional steps at that time. To sort of give a bottom line to what came out of that workshop, and then I'll kind of talk more about the classification system, is that there was consensus that there should not be any changes in the definitions of the fetal heart rate parameters that came out in the 1997 consensus document. The changes that were done was to stop using the term reassuring and non-reassuring as a medical description of the fetal heart rate pattern due to the non-specific nature of these terms and the challenges they presented as well medical legally. There was also a discussion to remove the term hyperstimulation as it described uterine contractility and replace it with the term tachysystole with and without fetal heart rate parameters. And then at the end of the day, after the end of the few days after all the discussion, there was an adoption of a 3-tiered fetal heart rate classification system. So why did we need a classification system? If you go back to the genesis of that consensus conference and why we need to do things differently, the workshop in 1997 did an excellent job of providing definitions and nomenclature, but these were all about individual parameters. And there was very limited information with that document to provide pattern recognition, putting all the individual parameters together to give a gestalt of interpretation. With those individual parameters, and the information that came out after that, there certainly was some suboptimal agreement and reliability of these individual parameters to predict adverse outcomes. Finally, a major gap was that there was not published, agreed upon evidence-based guidelines for management based on these patterns. And in order to do that well, the thought was that we needed to have a classification system. So with that goal in mind, the group there was discussion, and then individual groups were tasked to try to combine these individual parameters into a classification system, and then have that be done in such a way that interventions can be tailored. What came out of this was a 3-tiered classification system: normal, indeterminate, and abnormal. Believe it or not, there was a lot of discussion about what to call the middle category, category 2. Should it be equivocal? Should it be unknown? Ultimately, it was determined as indeterminate. And I'm going to describe a little bit each individual category. So there was a robust discussion at the time about what type of classification system should be adopted, because we were essentially working with a blank whiteboard. There were certainly some other societies in Canada, the Royal College, Australia, who had adopted some version of a 3-tiered system. So there was that was published and had been used. And there were some representatives from those organizations that attended the conference and gave their feedback on those systems. In practice, even though we didn't use the term, we were for many years using a 2-tiered classification system, reassuring versus non-reassuring, one or the other. So that was a 2-tiered system. There was a discussion of 2 other types of classification system. Dr. David Miller presented his algorithm and classification system that was very pathophysiologically oriented, which I think is an excellent concept and a great teaching tool for understanding the pathophysiology of uteroplacental insufficiency during labor and treatment. There was also a robust discussion of a 5-tier classification system that was being employed at the University of California in San Francisco, as well as some hospitals in Japan, that had been published a few years earlier, that used the Homeland Security warning colors to classify fetal heart rate pattern. There was a discussion over this. One of the challenges with the adoption of that system was that it had been tested not as much. There was less available literature. It wasn't used in other centers. There was concern that it may be too complex at this point in time. And that was ultimately, my summary of the rationale for not using that system, even though it had some terrific benefits. The other major decision that was made was that the classification of fetal heart rate variability for category 3 tracing was put as absent with other findings. There was some robust discussion about whether or not minimal variability plus other parameters was predictive enough of being at risk for acidemia in order to classify as that, and the consensus at that time was that it was not, and therefore a more conservative approach was used for absent fetal heart rate variability. After the consensus conference, the ACOG was tasked with translating the information from this conference into management and how to roll out these concepts into clinical care. And this is done really in two practice bulletins. One was number 106, which was published in July of 2009, and it focused in on the adjustments to nomenclature and interpretation and described the classification system, whereas then the second practice bulletin, which was number 116, which was published in November of 2010, focused in on specific management strategies based on the classification system, and I'll talk about each one a little bit. It doesn't do you very much good if you've got an evaluation and classification system that isn't tied to management. And that's one of the real strengths of the second practice bulletin. If you take a look at, this is figure 1 in the practice bulletin, and I'm using this red dot. On the far left-hand side was the description of management tied towards the category. On the far right-hand side is the specific management of Category 3, and then in the middle is a little bit more of a breakdown of Category 2. There's a real concerted effort amongst those that authored and then reviewed this practice bulletin to try to translate this into a usable algorithm that labor and delivery nurses and physicians could bring to the bedside. So Category 1 was described as normal, with a normal baseline, moderate variability, the absence of late or variable decelerations. You can have early decelerations and still be in Category 1. You do not have to have a reactive stress defined as 15 by 15 in order to remain in Category 1. That's something that our new physicians sometimes struggle with. This is a classic description of a Category 1 tracing: normal baseline, accelerations, moderate variability in the absence of decelerations. Category 1 is actually very simple. It's strongly predictive of normal acid-base status, and you follow up in a routine manner. The decision was made to allow individual units to describe what in a routine manner is. In some situations, it may be appropriate or may be reasonable to do intermittent monitoring or to do different frequency of monitoring depending on the patient population, but the practice bulletin is very simple in its description. To get the next step would be to take a look at Category 3. I think that looking at Category 1 and 3 are much more straightforward. They're almost like bookends. Category 3 is very abnormal. If you really pause for a minute and look at the definitions that are used for Category 3, it's absent fetal heart rate variability and recurrent lates, recurrent variables, bradycardia, or a sinusoidal pattern. These fetal heart rate patterns, fortunately, are extremely rare, and we can talk a little bit about some of the epidemiology of these, the frequency of these patterns. But this is a very, in my mind and an opinion, a small subset of tracings. It's challenging to find tracings that are in Category 3 in order to do lectures. It's absent with recurrent late decelerations. This was described as a Category 3 tracing. This is another strip that was described as a Category 3 tracing at the time, absent variability with late decelerations. It is so unusual that it requires prompt evaluation and supportive measures to try to resolve or prepare for delivery. I think that the majority of obstetricians and experts would argue that if you have pattern evolution that gets to the point of a category 3 tracing, it would be unusual to come back into a pattern that is not as extremely suggestive of acidemia, such that any resuscitative measures should be done in preparation for operative delivery, whether it's cesarean delivery or operative vaginal delivery, depending on the stage in labor. And again, if you take a look at the algorithm category 3, it's in particular preparation for delivery. Depending on your practice setting, you may require calling in a surgical team. It may be getting anesthesia there. It may be preparing an operative room. And during that downtime or during that prep time, regardless of the time interval, even if it's short, you certainly have the opportunity to do some resuscitative measures such as fluid boluses, lateral positioning, oxygen. And if not improved, consider prompt delivery. Certainly the decision-making for going towards delivery is very abbreviated once you get to a category 3 tracing. The other teaching aspect that has come up shortly after the category systems came out is you're not required to wait for pattern evolution for a strip to get to category 3 to do a cesarean delivery for fetal indications. There are certainly some category 2 tracings that would fall into the category of being highly predictive of fetal acidemia and warrant emergent preparations for delivery. So category 2, which is really where the challenge is in the NICHD classification system. It's essentially everything not in 1 and not in 3. And it represents a pretty wide heterogeneous range of tracing. So it can be either moderate or minimal variability with different types of decelerations. This would fall into the category 2 tracing. It has a normal baseline. It has moderate variability. It has recurrent variable decelerations. This, in theory, was described as a category 2 tracing with tachycardia, minimal variability, and recurrent late decelerations. This certainly is a very abnormal tracing that may warrant preparation or urgent delivery if it continues or didn't respond. This is another example of a category 2 tracing, again with minimal variability, recurrent decelerations. This again is a short window of a tracing. You see some of the heterogeneous ranges. And this finally is another category 2 tracing. This is a patient that was in the second stage of labor. You can see expulsive efforts down here. You can see recurrent decelerations. The baseline was approximately in the 140s here. This is a patient that was participating in a study that used fetal pulse oximetry. You can see the pulse oximetry values here. You see the variability when you do have some elements of the baseline. This patient had a second stage of about 3 hours and maintained this strip during that time period and was delivered with normal APGAR scores and normal umbilical pH. My point in showing these tracings is that there's very heterogeneous, and certainly management is not going to be the same for all these tracings. So what do you do with a category 2 tracing? You reevaluate it. You may do additional tests. And in theory, what's described as non-surgical interventions, I certainly would argue that there are some category 2 tracings that are appropriate to proceed promptly with surgical interventions if your interventions or your testing didn't provide information that was reassuring. One of the other unique aspects to the second practice bulletin regarding management is that it's very specific or provides information on tailoring in an intervention to a specific fetal heart rate abnormality. This pairing of the interventions to the abnormalities are not, it's not novel. It's been described by experts for quite a long time, but it's one of the first times done in a practice bulletin that pairs up an abnormality specifically with an intervention. The second practice bulletin. Like I said, the practice bulletin, that aspect of it doesn't really provide unique information. I think that one of the things that I like to refer our residents and other trainees to are a series of papers that David Miller and Lisa Miller have done that kind of walk through the relationship between electronic fetal monitoring changes and some pathophysiological principles. This was recently published in the Gray Journal in this year, and I would encourage everybody to share this with their residents, and it's a great resource that kind of puts everything together. And again, I think that the unique aspect of the practice bulletin is to give a pathway of interpretation and then management. I'm going to talk a little bit about what happens with this category 2 here. It gets broken up into two essentially pathways. On the left-hand side, if there is accelerations or moderate variability, that's strongly indicative of a normal acid-base status. Given that fetal heart rate variability is the most specific, sensitive and specific indicator of oxygenation and acid base, if they're present, that certainly categorizes the strip in that. If there is absent fetal heart rate acceleration and decreased fetal heart rate variability, then there is a increased chance for fetal acidemia. And additional testing, which could be done with adjunct maneuvers such as scalp stimulation, vibroacoustic stimulation, in those rare situations where certain sites are still doing scalp pHs. This would be the area or the role to gain additional information regarding acid-base status in order to continue on pregnancy, continue on with labor at the same time that you're doing your resuscitative measures. So the next, I'm going to talk for about 15 minutes about what research has been done and published regarding the three-tiered classification system. There have been, over the last several years, several papers that have been published, mainly in the American Journal or in the Green Journal or in the American Journal of Perinatology regarding different aspects of the classification system. Additionally, there are a plethora of abstracts that have been presented at various meetings, in particular the SMFM, that deal with certain issues, but I'm going to focus in on the manuscripts that have been published in the peer review literature. In 2000, in the last couple of years, a publication came out from the University of Utah, where Mark Jackson was the first author, and which described a very large cohort, the frequency of these NICHD categories in across their population. One of the questions that was unknown, since the classification system had never been used in the United States, and it was very new, was how often do you see certain patterns over the course of labor? And this table too, I think, provides some useful information. In these columns, it describes the relationship between the specific fetal heart rate category and the overall labor monitoring. And then the last 2 hours are over here to the far right. And if you take a look, I'm just going to focus in on all patients, and I'm going to focus in on the percentage of the total here, if I can go across like this. If you take a look at the overall labor monitoring, the percentage of the total, somewhere around 77.9% of the strips as they were evaluated at a point in time were category 1, 22% were category 2, and well less than 1% were category 3. If you take a look at the last 2 hours, there's a higher frequency of category 2 tracings and about the same as category 3. So this provides some sort of population information regarding how often you're going to see these categories, and I think that this validates a lot of people's thoughts on what the frequency was going to be, but this provides high quality data about it. Another piece of data came out that was published in the Gray Journal, a few years ago, where it was looking not at in a cohort population, but more of a case control population that was comparing the frequency of category, the NICHD categories for different types of strips, showed that the majority of strips were in category 2 and less in category 1. This, again, as I said, was a case control study, so you have to accept those limitations. I think the important aspect is to recognize that it's a pretty small percentage of category 3 tracings, even in those cases where you're having quite a low pH. Another useful piece of information came out, was published 2 years ago. It was presented at the Society of Maternal Fetal Medicine meeting in San Francisco, and then published subsequently in the Gray Journal, which described the level of agreement between users regarding the category systems. 3 MFM physicians who were blinded to the clinical information individually interpreted the fetal heart rate patterns in 20-minute epochs, and then their level of agreement amongst each other was tested. Each of these 3 physicians were involved in the NICHD consensus conference. I think the useful information is that the level of agreement is shown in this far area here was moderate for category 1 and category 2 in overall. The area where there was poor agreement was the disagreement over variability regarding absent variability or minimal variability. Recognizing that if you have absent variability with recurrent decelerations, that puts you into category 3. If you have minimal variability by this classification system, that puts you into category 2. Our interpretation of this is that it probably wouldn't have a clinically significant difference in patient outcomes, because those category 2 tracings that have minimal variability coupled with recurrent decelerations are still so abnormal they would warrant prompt evaluation and intervention, and then proceeding towards operative delivery if they didn't respond. However, that is speculation because it's not been tested. Another analysis came out and was published in 2011 that compared the classification, or the fetal heart rate patterns, comparing the 3 different classification systems, the 2-tiered versus the 3, and then the 3-tiered versus the 5-tiered system, which I'll describe in a minute. Cynthia Giampi-Vannerman from Columbia was the first author for this, and this was, I think, certainly the first paper, and I'm not aware of other ones that have been published yet. I'm sure some will come, where it compares what categories each of these come into. So if you take a look, and on this side of your table, this is the 2-tiered, either reassuring or non-reassuring, and up here you have the 3-tiered system. So if you take a look at of those strips that were in categories as reassuring by the observers. Half were in category 1 and half were in category 2. Of those strips that were categorized as non-reassuring, following that criteria that had been published previously, the majority were in category 2 and a small number were in category 3, and none were in category 1 at all. The next comparison, which I think is, let me see, where did that go here? The next comparison that Cynthia did was comparing the information from the 3-tiered to the 5-tiered Ferrer classification system, and I'll talk about the 5-tier in a second here. But you see the 3 tiers here, 1, 2, and 3, and then you see the 5-tier up here, which is again categorized by colors: green, blue, yellow, orange, and red, with more green being the most normal and red being the most concerning, again being created following the terrorist watch list information. Of those strips that were done as category 1, overwhelmingly the majority of these were in the green category for the 5-tiered system, and a small percentage were in the blue. That's very reassuring. And as the 3-tiered classification system, there weren't that many of these strips that were in category 3, but all of them were in red. So I think that was also reassuring of a good concordance between the extremes of both of these classification systems. And then interestingly, category 2 was all across the spectrum here. So there were a fair distribution of category 2 strips in green, blue, yellow, orange, and red. And certainly if we remember back to those example strips that I showed of category 2 tracings, it's probably not surprising. So I'm going to go back. I'm going to mention another piece of literature that just recently was published, again by the group from Columbia, that evaluated the predictive value of the 5-tier versus the 3-tiered system in identifying fetal acidemia. They found that there was a significant difference and an improvement in the predictive value using the 5-tiered compared to the 3-tiered system. There aren't many studies that have been done that evaluated this research question. This study has some limitations of sample size, but it is what it is, and I think it's useful as we try to put things together. The other aspect that I think is very important to touch in on is the 5-tiered system. So several years ago, a framework for the standardized management of intrapretum fetal heart rate patterns was described using a classification system that I think is very thoughtful. If you look here, the classification system, the perception of the risk of acidemia, the risk of pattern evolution. I think that this is a concept that's very important. And then it's linked with action, what you should do about the pattern that you're seeing. This is a table that helps describe the individual patterns into different colors. There is a cheat sheet that can be done, it can be given to people on labor and delivery that corresponds to the colors. If you take a look at the abbreviation, this is blue, yellow, orange, red. There is an educational device that some people use as tiny little laminated cards, or put them up near the bedside that help very quickly give a reference card to it. But it uses, it incorporates variability, moderate, minimal, and absent, and then looks at different types of decelerations and the severity of the severity of decelerations as well. So I think that the challenge of the 5-tiered system is this a system that is generalizable outside the institutions that have spent many years developing it, refining it, and teaching other healthcare providers how to use it? Is it able to have adequate reliability amongst users? And then does the interventions that are matched off of the individual parameters, do they make a difference? So the next step after evaluating the classification system is implementing this into clinical practice. And there's a few key things that I think are really important as we interact with our other stakeholders on labor and delivery, our nurses, our residents, our referring private providers. And I think that situational awareness is something that's very important. In the patient safety literature that's coming into the obstetrical and maternal fetal medicine literature, this is something that is being adopted across many centers. It's really, really important when you're teaching people how to interpret the fetal heart rate, or you're doing it collaboratively with others, to be very systematic and consistent in your evaluation. We try to describe a Rain Man approach, where we go in a very specific order with this very specific format that doesn't allow people to jump around, and it allows them to be very systematic. Much in the same way that a radiologist is going to be very systematic of the way he or she interprets a CAT scan of the head, the way a gynecologist evaluates the pelvis at laparoscopy, or a cardiologist evaluates an EKG. Additionally, the context really matters. Not all fetuses are created equally. Gestational age plays a very big role. Your relationship towards potential underlying infection with rupture of membranes, maternal vital sign changes that may have been affected by a recent epidural, women undergoing trial labor after cesarean. All of these things are key into how we interpret the fetal heart rate pattern. And you cannot look at the fetal heart rate pattern in a vacuum. Finally, I think it's always relevant to learn from our mistakes. If you take a look at the published studies that talk about medical errors or medical legal allegations, largely it's about communication. So the small portion of these have a failure to recognize abnormal patterns, but the majority are about communication. Hopefully the 3-tiered classification system is helping improve communication. Certainly we hope that it's also translating into improved communication regarding intervention, and then improving the ability to timely intervene once these abnormalities are noted. Finally, checklists are being strongly advocated by the college. They're being used all across their specialty for different things. We try to teach essentially a checklist approach to our people at the beginning of their obstetrical careers to evaluate and assess individual parameters, choose a category, have that situational awareness to get an overall interpretation of a sort of a gestalt of good or bad, sick versus healthy, deathly ill versus not, and then translate that into action. What should you do based on the information that you have, and how quickly do you need to do it? And I think this sort of systematic approach is very helpful, especially in those time periods where you're not where you need to intervene very quickly, or you're in areas where very abnormal or bad things happen very infrequently. So my closing comments are that The three-tiered system has been in existence now for 4 years. There have been a scattering or a smattering of studies that evaluate the reliability, the validity, the frequency of these individual categories. There isn't data available yet on whether it's resulted in differences in perinatal outcomes. I think that we are at a point in time that it's a very fair debate about whether or not Category 2 is too large or too heterogeneous. As part of that debate, it's not clear and it's very unknown if it really matters whether or not you would have 3 tiers or 5 tiers and what you would do with those patterns in between. I think it's also not unreasonable to have a discussion and recognize that any or all classification systems that rely on visual interpretation are flawed by the users and by the technology. And a more realistic approach may be to minimize the limitations, use the interpretation in the most optimal way, and await a new or different technology that improves the science. With that, I'm gonna stop and thank you for your attention and be happy to answer any questions.
Thanks, Dr. Blackwell. It was great review. I want to open the floor at this point to any questions. Again, there's a couple of different ways you can ask questions today. One would be to type in a question under the question and answer tab. And once those are typed in, then I will pass those along to Dr. Blackwell. The second way is if you have a web camera or a microphone available, select the feedback button in the upper right-hand corner of the screen, and I'll call on you, and you can ask Dr. Blackwell a question directly. Just as a reminder, while people are furiously typing, the next lecture is July 18th. There's no lecture on July 4th. The next lecture is July 18th to begin our research series. So tune in. That'd be great for brand new fellows to log on at that time. While we're waiting for questions, Dr. Blackwell, I have one. Since the 3-tier system has come out, have we seen a change in the way fetal monitoring is used or influencing medical legal cases? Do you know if there's any data about different ways that that's come up in cases or supporting cases or being used to say you should have intervened or you should have done, this category 2 says you need to do something. If it doesn't change, you need to intervene right away.
I'm not aware of anything published yet, and anecdotally, I haven't seen it on a frequent basis get translated into new cases. It has only been 4 years, and oftentimes there's a delayed tsunami before something new and fetal monitoring occurs before it affects the medical legal environment.
Right. Great.
There's so many other things going on in obstetrical care that may have more of an effect in those things. The absence of or the significant decrease in VBACs, the higher cesarean delivery rates overall, those may be having much more of an impact compared to changes in nomenclature or classification systems.
Right. Great. So I'll give another minute or two here and see if others have questions. So UConn has a question. Was the NICHD system based on objective data or was expert opinion used for research?
I think that's a fair and good question. I think that there are some published data that provides information about a system that puts patterns into 3 categories. Not a lot of data, and certainly that was discussed at the consensus conference. These other classification systems, the 3-tiered ones that were adopted by the Canadians, by the Royal College in Australia, are slightly different than ours. Just the way they practice medicine is different. I do think that there was a significant amount of expert opinion in what parameters fell into these categories, how they were defined, just limited information regarding other aspects to it. Example that I gave about the where do you put minimal variability plus recurrent decelerations in a category 3 or in a category 2? That was largely based on expert opinion because that's all that existed.
Sure.
I do think that at a point that we're going to reach a point in time where we're going to need to evaluate how to do category 2 differently or adopt other systems depending on what comes out of the STAND study that's testing ST analysis as an adjunct to fetal heart rate monitoring.
All right, great. Well, we'll give out one more call for questions. See if anybody has any other comments or questions or.
I think that this area is still ripe for research publications. As I mentioned, there's been a smattering, but not an overwhelming number. Fellows are able to come up with an interesting idea to evaluate what's here. Potentially looking at temporal changes in intervention rates based on when people started using the 3-tiered system at their institution, that type of stuff. Looking at how frequently the category systems are documented. Looking at what categories for those fetal heart rate cases where a cesarean delivery is done for fetal indications. Getting an idea what category those are at the time of the decision. I think that those are areas that would contribute to the literature.
I agree. I would love to see what the average pattern is, either by the 3 or 5-tier system for indication for non-reassuring surveillance for C-section. It'll be interesting to see. Well, I think you've instructed everybody. So I want to thank Dr. Blackwell again for another great talk. Again, nothing on July 4th. We'll see everybody on July 18th for our research series. Thanks again, Dr. Blackwell, for another great lecture.
Thanks and have a good day.
Have a good afternoon. Thank you.